Welcome to another episode of the PFC podcast. The opinions you hear are ours and doesn't necessarily reflect anyone else's. Now on to the podcast.
Welcome back to the PFC podcast. Today we're going to talk about sepsis treatment and management. Today I'm with Doug, Jabon, Jay, and Paul, and we're going to hash out this scenario.
While on deployment to the Democratic Republic of the Congo, an elderly man came to us complaining of coughs, chills, shortness of breath, and feeling very tired for about a week. Since this was about the 900th patient I've met here with those same symptoms, I didn't think too much of it and brought him to the clinic. His initial vitals were heart rate of 93, respiratory rate of 23, blood pressure 106/46, temperature 102.1 Fahrenheit, and SpO2 95% on room air. He was lethargic, but could answer questions. On exam, his breathing was shallow, regular, and labored, with coarse crackles in the lower lobes. When I asked him to take a few deep breaths, he coughed thick, nasty, yellow-brown sputum into the mask I had given him to wear. The cardio exam was normal, besides tachycardia. No extra sounds, and his skin was warm to the touch in all extremities, both distal and proximal. Cap refill less than 2 seconds. Welcome to PFC.
So for anybody here, is this patient sick or not sick?
Great question. This is Doug, ICU doc. This patient is definitely sick.
Thanks, Doug.
Would you like me to explain why?
So I think the decision to say, okay, yeah, he's sick is pretty easy, but what I'm getting at is what mental models, what tools do you use to actually make a decision that this guy, he doesn't just have pneumonia, he's really sick and we really need to do something about it?
Well, what you're seeing is, a set of vitals, and you're seeing a set of symptoms and some signs. And whenever you make your assessment of a patient, as you say, sick or not sick is really the first thing that should go through your head. And that includes injured or not injured, or badly injured and not badly injured. I mean, I say sick or not sick for pretty much any etiology of insult to the person. And it should be, like I tell our residents and medics that I teach, it should be a recipe, not an ingredient, right? If you hang your diagnosis on one ingredient, i.e. the vital signs, and not the symptoms, you'll miss some people who have abnormal vital signs but are clinically well. And if you hang it just on the symptoms and not the vital signs, you can make similar. So you pull in all this data quickly and form a sort of a composite whole of your patient. And this patient, by both vital signs and symptoms, is sick. The symptoms are obviously pointing toward an infection, and the fact that the vital signs are abnormal, he's tachycardic, he's tachypnic, he's febrile, and he's hypoxic. You can argue if he's hypotensive or not. I don't know what his baseline is, but you could even argue that he's hypotensive. Are all painting a picture of concern for an infection in a patient who's seeing systemic effects of the infection, which point you to the diagnosis of sick. And then the other question to ask is he stable or unstable? And my gestalt would be looking at all of this, seeing the history. He's been doing this for about a week. He if he is stable, he might be fixing to become unstable because this has been going on and he's been compensating for that long. And that's another thing you have to run in. If the patient looks stable, do they have the potential to become unstable? And that's the snapshot that you want to form in assessing every patient. And from then you get involved with them, and then you start trending them over time, and then you see how they respond.
Yeah, this is Jay. I agree with Doug that this is probably a sick patient. I tend to look at patients through a spectrum and place them on a, do I need to react immediately, quickly, or later? and I probably would put this guy on the quicker side, but he's not somebody I need to, for example, intubate and start doing compressions on. Obviously. I am concerned also about his mental status. I think that is probably one of the signs, like Doug said, that points to him being on the sicker side. Any time someone's mental status is compromised, that's really concerning.
Yeah, that's a great point. We talked about signs, we talked about symptoms, we talked about vital signs, and then, right from the snapshot, you have a picture of organ function or organ dysfunction, and the one thing that you can get at the bedside is mental status. Everything else you need some sort of diagnostic maneuver to assess, unless they tell you, hey, I haven't peed for 2 days, in which case you may get it from the history as well. But so bad vital signs, bad symptoms, been going on for a week with evidence of organ dysfunction in terms of his lethargic mental status, that's a concerning patient. Stable for now, agree, doesn't need to be intubated or criked and put on a ventilator, but definitely with the potential, and given his age, the potential to become unstable.
Okay. Especially with sepsis, there's a lot of tools to use, things like the QSOFA score, the PRECEPT score, and there's a variety of others, and all of them are debated to some extent. Especially for the non-clinician, a provider that sees these patients constantly, is there any utility in a tool like this?
Boy, you cut right to the thorny issue with a second question, Dennis. Strong work. This
Off
is
the top rope.
This is Doug, and like I said, I'm an intensive care doc. The Sepsis 3 and the SOFA scoring that underpins its prognostic intent, and the QSOFA, which is a sort of a reduced scoring system, again, to give it some prognostic significance, have not changed my practice in terms of diagnosis. And I think it's important to get this point up front, is that especially in the management acutely of any critically ill or injured patient, what you want to be looking for are things that improve your diagnostic accuracy, because accurate diagnosis is going to lead to correct management, and prompt initiation of correct management is the best thing that we have to offer these patients who are in some form of circulatory shock or heading that way, whether it's from blood loss or infection or heart failure or whatever. So I stick with the most time-honored quick diagnostic aid, which is the SIRS criteria, the Systemic Inflammatory Response Syndrome criteria, which are we can get into if you want me to recapitulate them, but I think and those were originally developed for sepsis back in the early 1990s, when the mortality for severe sepsis and septic shock was 50% or greater, and in a big consensus conference between the National Association of Chest Physicians and the National Institutes for Health got together and said, what can we do to improve the timeliness of diagnosis, because it was felt like delayed diagnosis might be contributing to this excess mortality or high mortality. And SIRS criteria were postulated. They were then tested in a trial that was reported in JAMA in 1991 and found to be about 97 or 98% sensitive. And they were actually retested in the early 2000s, and the sensitivity slipped a little bit, but still in the high 90s. And for early diagnosis, what you want is a test that's sensitive, because you would rather have some false positives that get antibiotics and resuscitation that they don't need than have false negatives that you miss and you don't treat them and they die because of a misdiagnosis. And so QSOFA is for sepsis 3 is actually a specific test. It has it gets a higher percentage of the positives, but it also misses some false negatives, and so you miss some. You have the risk of missing some cases, and I don't think that's anything in our line of work that we want to do. So I stick with SIRS. evidence of infection, whether it's CNS, pulmonary, respiratory, GI, skin, soft tissue, or systemic, bacteremia. We just had a case of that in our ICU last week, and as my diagnostic criteria for sepsis.
Yeah, this is Jay. I agree with what's been said in terms of diagnosis already, and to make it even simpler, I think that just simply looking at vital signs, irregularities, is incredibly helpful. That's more or less what the SIRS are, more or less. So if you use the strict SIRS criteria, like you may, be misled in, certain, in either direction. But just watching the vital signs, I think over time, especially, is helpful in order to get a clear picture of the patient and what their clinical status is. I often tell my patients, the ones that I discharge especially, that disease changes over time, and so although sometimes we don't find something that's wrong in the patient, if there's something wrong, then with time that picture will become clearer. So watching the vital signs over time, I think, is can be incredibly helpful, especially for the medic who may not have, who definitely doesn't have the same kind of training and experience that doctors have in terms of numbers of hours, and number of patients that they've seen. So watching those vital signs over time, I think, can be very helpful. And then also being aware and sensitive to, to that inner voice that you might sometimes hear. Even though someone's vital signs may be normal, if they're not acting normal, or if there's something funny, you may again want to watch the vital signs over time and see what happens. Case in point was a patient that I had about a year ago whose chief complaint was confusion. This guy came in, his wife brought him in. He was a youngish guy, maybe in his 50s or so, and he was a little bit confused. He didn't know where he was or what the date was. His vital signs were normal, and I did I interviewed him, and he was just a little bit confused. And then I did an exam, and he had a tiny little abscess at his umbilicus. And I thought to myself, well, maybe this guy's septic. He's confused, but his vital signs are all normal. So let's watch him, and let's see what happens. I drew a lactate and white blood cells. I think his white blood cells were elevated, and maybe his lactate was a little high, because I ended up admitting him, and subsequently he became hypotensive. And his vital signs at that point in time became deranged. But at the initial presentation, he had normal vitals. He just had this kind of unique and weird presentation that, honestly, I've never seen a patient present with sepsis with the only complaint of confusion until that time.
Yeah, I could imagine probably two scenarios seeing out in the field: either the early end of the spectrum where the man just has a cold, or the other end of the spectrum where somebody's carrying him in, not knowing why he's collapsed. I think the far end of the bad end of the spectrum is probably not going to be super hard to know that you need to go. The guy has a black arm. Oh, I think he's septic. But I guess what concerns me is that guy who has sepsis and is mixed in with everybody else that has a cold, and knowing in my head I have a way to sift him out from all the others. But yeah, using the SIRS criteria, using what you've been practicing over and over throughout the years of looking at vital signs, looking for abnormalities, checking mental status, and then over time you've just developed this whatever gestalt, if you want to call it that, of that guy is sick. I don't know why he's sick, but he just looks sick, so I'm going to look further. So we've all agreed that this guy is sick. So both in our protocols and in Jabon's class, we know the next step is to provide antibiotics. Early antibiotics have been proven to save lives. What would you want to do first? Would you go with the biggest gun antibiotic that you have? Or would you want to wait for labs that may or may not be there?
So this is Jabon. if you have access to labs, they can be beneficial, but typically you're making your decision on what antibiotics that you're going to use before the labs that are truly going to tell you what antibiotics to use are going to come back. So those are things like cultures and sensitivity that can take days to grow. So typically you're going to look at what the source of the infection is and try and decide what's the typical bacteria flora that would be involved, and then what antibiotics or antimicrobials you have that would then cover that spectrum of bacteria to try and get it under control. Another option is going after source control. So you made the mention of somebody who has like a necrotic arm or has non-viable tissue that you might need to perform some kind of procedure, incision and drainage, removal of that tissue. But I wouldn't wait for those labs, even if you have quick access to them, to start with the empiric antibiotic choice and then drive on from there.
Yeah, this is Doug. Especially in a prolonged field care setting, in an austere setting, and the sole provider, I would hit them with the biggest guns you have right away, and I wouldn't get too wrapped around the axle about defining the source. It's probably going to be pretty obvious, but you want to make sure you cover them for a broad variety of things. And generally that means gram-positive bacteria, gram-negative bacteria. A nice drug for the sick people that most medics carry is Rocephin. In lower doses, a gram every 12 hours. It's pretty good for most infections, except the central nervous system. In 2 grams, you're going to get central nervous system penetration for meningitis and encephalitis if you're worried about that. But in general, hit them early. By the time, if you're waiting, not that you would have them, but if we in the hospital wait for labs, we've increased our patients' mortality risk about 6 to 8% per hour for every hour that you delay getting antibiotics on board. And a patient with severe sepsis is an increase in mortality, 6 to 8%. So you wait 6 hours, there's 50 to 60% increased mortality.
All right. So this next question is something I've seen play out in a few scenarios here in the schoolhouse. Once you've given the antibiotics, are you really out of the woods yet?
That's an awesome question. No. In fact, things can get worse before they look better, because the antibiotics can actually, the antibiotics, if they are bactericidal, they kill bacteria. That the waste products from the dead bacteria can actually provoke a stronger inflammatory response, and the patient will get sicker. They'll get more tachycardic, they'll get more hypotensive, their lactate can actually go up rather than go down. And we usually say in the ICU, whenever we initiate broad spectrum antibiotics for a patient who's in severe sepsis or septic shock, give them 24 to 48 hours before we are assessing to see if they're working or not. And in those 24 to 48 hours, they can still remain febrile and have pretty profound SIRS criteria. And the other thing is, with source control, that can really provoke things too. We had a patient just this last weekend who came in with really, really bad kidney infection, but she was not in shock. She was in compensated shock, so she had organ dysfunction, but her blood pressure was intact. Well, as soon as they stuck a drain into that and released it, she went into shock and cardiac arrest. So, that's a tricky one. You can definitely get worse before you get better treating these illnesses.
So this is Jabon again. It's definitely not a fire and forget kind of situation. It's the first step, and it's the correct first step. But continue monitoring the vital signs, monitoring the patient, interacting with the patient, whether they're being held at your location or checking in on them frequently, because there's, like Doug said, there's definitely a delay between starting the therapy and then getting the benefits from the therapy, and there's a lot to watch between that moment and the moment that you're truly out of the woods.
One of the things they teach the medics in the ICU, rotate in the ICU, is that in prolonged field care, sick and stable is okay. That's not a bad goal, right? Getting worse is not good. Unstable is not good. But if you can get, let's say, this septic patient antibiotics started and they're stable, their exam is still abnormal and their vitals are still abnormal, but they're not getting worse, and they have some organ function, they have some sort of mental status, they're making some sort of urine. That's okay. If you can get them in that state to a higher echelon of care, an ICU-like facility, they're going to have a pretty decent chance of survival. And perfection sometimes can be the enemy of good enough. That if you try to make them look better, number one, they just might not be ready to look better. So you give them that 10 liters of fluid, and they're still not, they're still febrile, and they're still tachycardic, and they're still making 20 cc's of urine an hour. And now they're in respiratory failure from volume overload, and you've got to worry about managing their airway with, sedation drugs that you might not have and a ventilator you might not have. So that's a consideration. If you can stabilize them and get them to a higher echelon of care, that's a pretty worthy goal.
I think something that is worthy of being discussed is the disposition in some of these patients, because it's easy to know where that soldier patient is going to stay with you when they're as sick as the patient Doug just described. However, when someone has sepsis but they look well, that doesn't mean that they're going to continue to look well and that you should send them back to their to their CHU or wherever they're staying and leave them untended, because these patients can turn south. I would be wary of treating a septic patient and then letting them leave your site or go very far away. Even if they look well, you may want to have them sleep in the cot in your aid station, or at least have a buddy in the room that can check up on them. In my experience, in the Army, I've seen a couple of soldiers die of sepsis, from a couple of different sources, because they were left alone to sleep it off, even after they've been treated with antibiotics. So just be wary of that, and keep a close eye on these guys with sepsis, even if they look okay.
Totally agree. Any infection or any process that's severe enough to provoke a systemic inflammatory response, that's the definition, it still is the definition of sepsis. Even after sepsis 3, the definition is still 2 or more SIRS criteria with presence of infection is sepsis. Severe sepsis is 2 or more SIRS with infection and organ dysfunction, and septic shock is all of the above with low blood pressure, mean arterial pressure less than 65 after a volume challenge of 30 cc's per kilogram. Even at that very early level, where you've got patients with mildly abnormal vital signs and they're not in any organ dysfunction, the fact that they're riled up that much by their infection means they should be watched and vital signs trended, and with a medical attendant ready to intervene quickly for at least minimum of 24 hours.
All right, just to catch back up in the scenario. So this guy came in, we decided he was sick, and he was sick enough that we decided to give him antibiotics. Now we realize, hey, you know what, I'm probably out of my depth just a little bit, so I'm going to call up Doug on telemedicine and tell him what I have, tell him what I've done, how long this has been going on. Now, I want to ask you, his vital signs, his blood pressure is starting to slip.
Mm-hmm.
So I know that the next step, I need to get fluids on board, and if that's not working, I need to start thinking about pressors.
Mm-hmm.
So when you're in the hospital and the vital signs are starting to go south, how do you handle the fluids and vasopressors?
So any shock state, of which sepsis in the United States or maybe even in the Western world is the most common cause of circulatory shock, even though we deal with hemorrhagic shock more in the military, it's in civilian practice, a small percentage of the amount of circulatory shock you see. The management is always 2 parts. It's treat the cause and resuscitate, and that should just be a reflex. Treating the cause without resuscitation, the patients don't do as well. Resuscitating without treating the cause, the patients don't do as well. You have to do both. It has to be a reflex. It has to be simultaneous, right? So as you are starting antibiotics, you have to decide, does this patient need resuscitation? Now, if they don't, you can hold off. But in this guy, he's got altered mental status, so he's already got end organ dysfunction, which requires resuscitation. So I'm going to initiate both. And so fluids in resuscitation septic shock is a bolus crystalloid challenge, IV or IO, up to 30 cc's per kilogram. So I don't know let's say this guy, weighs 100 kilograms. I guess, let's say he weighs 100 kilograms. There's 3 liters, right? So I'm going to give him in boluses because I want to expand the circulatory volume and augment preload. That's the volume of fluid that's delivered to his heart to improve cardiac output, which should improve blood delivery to these organs that are dysfunctional from lack of oxygenated blood. I want to give them up to 3 liters. Now you can do it, in an older person you might do it 500 cc's at a time because you don't want to overload their heart or overload their lungs. But my safety limit is going to be 3 liters. If he hasn't responded to that, he's probably not going to respond, and giving him more is only going to run the risk of complications, primarily pulmonary edema and respiratory compromise. And at that point, then I'm making the transition, if he's still hypotensive, of transitioning to pressors. And if I transition to pressors and he still really doesn't urinate, I'm probably not going to hit him with a whole lot more fluid. I may just, say his kidneys are on their own. Now, obviously, this is a local guy in Africa. That's a little bit different situation than if we're treating one of our soldiers. If we're treating one of our soldiers, there's the expectation that he or she would get organ support with, for instance, dialysis if they needed. That would be how I would process one of our guys. With him, with a local guy, I don't know. I'd probably do my fluid management a little differently. I probably would go beyond that, but because I don't have dialysis. But that's it. Fluid challenges, set yourself a safety limit, and 30 cc's per kilogram should be your initial safety limit. Look for some sort of response. What are you resuscitating? Or what's your marker of resuscitation? In him, it would be improvement of his mental status, less lethargic. I'd probably put a Foley catheter into him and see what his urine output was. If it was okay, then again, my end point of resuscitation would be mental status. If the urine output was low, then I'd have 2 points, urine output and mental status.
What goals are you chasing for perfusion and urine output?
Well,
because he's not a hemorrhagic shock patient like we would do. You may do like
Sure.
hypotensive resuscitation. Oops, sorry. You might be doing hypotensive resuscitation. That makes sense. But this is a septic shock patient with distributive shock. So do you target normal blood pressures, or are you still targeting the 65 MAP?
MAP of 65, right. I'm not, again, perfection is the enemy of good enough. And there's no data that making patients physiologic in resuscitation for septic shock improves their outcomes. It just runs the risk of volume overload. No, and one thing that I teach is that your indications for resuscitation can often be your markers for resuscitation, right? So markers of resuscitation